Hello friends, in this case we will see a small pupil management. We are taking a 2.6 mm incision as a main port and 23 gauge side port. First, we will try to dilate this pupil with dilating agents. Epitrate. This is a tonic pupil and not responding to the pharmacological drugs. So we have to proceed in the same way. I am just going under the pupil and stain the capsule. Staining of capsule is very important in such scenarios as it enhances the visibility of the anterior capsule and thereby make the steps easy. Trypan blue is washed away and anterior chamber is formed with viscoelastic material. While forming the anterior chamber, make sure you are not overfilling the anterior chamber as it can cause iris prolapse out of the anterior chamber. A Rexis marker with 5.5 mm size is used to have the idea about the Rexis size which we should have, and Rexis started with a cystitome needle. I am taking the edge of the CCC below the iris and thereby while rotating it I can judge the size of my Rexis. And it is good idea that you finish off this Rexis in a single go as that is a better and controlled way to do it. Once the Rexis is completed, hydro procedure is performed, and as soon as the hydro is completed you can see the anterior capsule flap has come out. That indicates that the nucleus has separated. I am using a blunt instrument in my left hand which is having a ballpoint tip and that cannot damage the posterior capsule. This has a slightly higher length to manage the pupil. And I go inside with the phaco probe, take out the extracortical material, and as soon as I can grab the nucleus, I will tilt it and crack it into two pieces. Once that is done, I will further divide this nucleus into smaller pieces, and as soon as each piece is coming out, I am taking it out with phaco emulsification. The setting here are vacuum of 350, a flow rate of 38, and phaco emulsification in torsional mode as 100%. Half of the heminucleus is taken out. The second half is rotated and taken out with the help of phaco quite easily. This is not a very hard cataract, so managing this cataract was not very difficult. Though going under the pupil was a risky job, and anybody should have a good stable chamber while managing this. Once the nucleus is out, anterior chamber is again formed with viscoelastic. This is an almost unedited case. Here I am going in with coaxial irrigation aspiration probe, and the aspiration starts with a subincisional cortex. Once the subincisional cortex is taken out, the probe is rotated and swiped from side to side so that I will have a more chunk of cortical material in its bore and it will pull the cortical material comfortably. One can use the bimanual irrigation aspiration cannula for this purpose. You have to be very careful while a cortical material wash, as the chances of PCR is very high when the posterior capsule is naked. Here I have cleaned the bag of cortical material. Anterior chamber and bag is filled with viscoelastic again, and this is followed by IOL injection in the bag. Once the IOL is injected into the bag, the leading haptic has gone in, and with the help of left hand instrument I am dialing the trailing haptic into the bag, and a cortical wash and a visco wash is performed with the help of again a coaxial IA probe. I hope you find this video interesting, and staying inside to the center of eye is very important in cases of small pupil. Thank you and good day. Do subscribe to our YouTube channel Dr. Pankaj Lande for more such exciting videos.